So again, welcome everyone to the Orlando GI Journal Club. This is November 1st, 2023. Our first study was published in the American Journal of Gastroenterology. It's a randomized trial evaluating computer-aided detection during colonoscopy in the community. There has been a growing interest in applying artificial intelligence in gastroenterology. In particular, there has been significant exploration into computer-aided detection or CADI devices to reduce miss rates during colonoscopy. Randomized trials, primarily in academic settings, have found CAD-E to achieve significantly higher adenoma detection rates and adenomas per colonoscopies compared to colonoscopies without CAD-E. Questions, however, remain as to whether CAD-E still retains its impact in a community setting. The aim of this randomized trial was to evaluate the impact of CAD-E on polyp detection in non-academic community-based hospitals. So this is a randomized trial. It's a multi-center study based in the United States involving 4 community-based endoscopy centers and 7 gastroenterologists. They included all patients at least 45 years of age presenting for screening or low-risk surveillance colonoscopies. All patients were required to have adequate bowel prep to be enrolled in the study as defined by Boston Bowel Prep Scoring System in all colonic segments. Patients were randomized to colonoscopies with and without CAD-E in a 1-to-1 randomization. The investigators used the EndoVigilant medical device, which is an artificial intelligence-enabled CAD-E software for colonoscopy. It augments existing white light colonoscopy in real time by highlighting colon polyps by displaying graphic boxes around the lesion on a monitor. The primary outcome measure was the adenoma per colonoscopy, which was defined as total number of adenomas detected divided by total number of colonoscopies, and adenomas per extraction, which is total number of adenomas out of all the polyps removed during the colonoscopy. The authors enrolled over 700 patients in this randomized trial. It's 382 in colonoscopies without CAD-E, 387 patients in colonoscopies with CAD-E. The mean age was 57.6 and 58 years, respectively. They were pretty evenly matched in male to female ratio, and the majority of patients were undergoing screening colonoscopies, 71.6% in the without CAD-E group and 72% in the with CAD-E group. Now, looking at the number of adenomas detected per colonoscopy, there was no difference between colonoscopies without and with CAD-E, at 0.67 versus 0.73. The number of serrated polyps found per colonoscopy was also mean of 0.08 in both groups. When they looked at number of non-adenomatous, non-serrated polyps when they were looking at number of non-adenomatous, non-serrated polyps per colonoscopy, there was a mean of 0.51 in the group without CAD-E, which was significantly lower in the group with CAD-E at 0.9. And this was statistically significant with p-value of less than 0.0001. When they looked at the polyps detected per colonoscopy, there was no difference between the two groups in terms of those less than 6 millimeters, 6 to 9, and 1 centimeter or greater. When they looked at the distribution of adenomatous polyps by Paris classification per colonoscopy, there was no difference between the two groups between detecting polypoid and non-polypoid polyps. However, the average withdrawal time was significantly higher in the group with CAD-E at 11.7 minutes versus 10.7 minutes with p-value of 0.002. 0.27. However, there was no significant difference between the two groups in patients who did not have any polyps. This is the detection rate. As you can see, there was no difference in adenoma detection rate for all colonoscopies in the two groups. Those without CADI, 37.2%, and those with CADI was 35.9%, with p-value of 0.774. When they were looking at the rate of serrated polyp detection in all colonoscopy, it was 6.3% in without CADI group, 6.5% in with CADI group, again, no difference, with p-value of 1. And then when they were looking at adenomas per extraction in all colonoscopies, it was 56.8% in with CADI and 44.8% in without CADI. And this was significantly higher in the group without CADI. They also performed a multivariate logistic regression to identify factors associated with identifying at least one polyp during the colonoscopy. And the use of CADI actually was not a significant factor when they were adjusting on adjusted odds ratio in the multivariate regression analysis. However, the use of a dual monitor was significantly associated with identifying at least one polyp, as was the longer withdrawal time. One of the main limitations of this randomized trial was that, obviously, due to the study design and the nature of the procedure, the endoscopists were not able to be blinded to the treatment allocation, the use of CADI versus no CADI. So the take-home point from this randomized trial is that, in contrast to previous studies, use of CADI did not result in statistically significant difference in the number of adenomas detected. And so the authors do propose that additional studies are required to better understand why some endoscopists appear to derive substantial benefits from CADI and others do not, and how to best use this novel technology in clinical practice. The next randomized trial is by Sesani et al. It is a study published again in the American Journal of Gastroenterology, looking at the role of biliary stenting in recurrence of biliary stones and complications after stone clearance in patients awaiting cholecystectomy. In patients when there is failure for clearance of bile duct stones or choledochilothiasis during ERCP, biliary stenting is recommended to prevent cholangitis. However, there is conflicting data from limited number of poor quality studies about the role of prophylactic biliary stenting in situations where biliary clearance has been achieved, but the patient is still waiting their cholecystectomy. So the aim of this study was to evaluate the effect of prophylactic biliary stenting after achieving biliary clearance in reducing recurrence of choledochilothiasis and biliary complications in patients who are waiting for a cholecystectomy. This was a single-center randomized trial based in a tertiary referral center in India. They included patients who had bile duct stones and concomitant cholecystectomy in whom biliary clearance was achieved during ERCP, with biliary clearance based on there being no filling defects on fluoroscopy on occlusive cholangiogram. They then randomized these patients who have achieved ductal clearance during ERCP into two groups. They either underwent biliary stent placement with placement of either a 7 French or a 10 French plastic double pigtail stents, or no stent placement. The follow-up period is 3 months, and the primary outcome measure was to compare the recurrence of choledochilothiasis between the two groups. They enrolled 66 patients in total in the study, 34 patients in the stent group, 32 patients in the no stent group. These are the baseline characteristics of the patients. Median age was 46 in the stent group and 46 years in also the no stent group. 64% of the patients were female in the stent group, 62.5% were female in the no stent group. Everybody had abdominal pain, 32% of patients in the stent group had jaundice, 53% of patients in the no stent group had jaundice, and fever was present in 32% in the stent group and 37% in the no stent group. When looking at the laboratory values between the two groups at baseline, the total bilirubin was 1.4 in the stent group and 2.4 in the no stent group, and this was statistically significant, which is interesting, I would say. By nature of this being a randomized trial, all the baseline characteristics should be not significant. Interesting. Okay, next. ERCP details. So the number of stones removed were multiple in 38% of patients in the stent group, 31% in the no stent group. And they do state that difficult biliary cannulation was encountered in 26% of the stent group and 22% of the no stent group. The total procedure time was not statistically significant between the two groups, 29 minutes in the stent group, 28 minutes in the no stent group. Post-ERCP pancreatitis was encountered in 3 patients in the stent group, but none in the no stent group. These are the outcome measures. The authors encounter the recurrence of choledochleothiasis, which is the primary outcome measure, in 21% in the stent group and only 9% in the stent group. And despite this fairly large difference, the p-value was only 0.306. In terms of the total number of complications encountered, this was significantly higher in the stent group, with complications of cholecystitis and 3 cases of post-ERCP pancreatitis. They encountered no complications in the no stent group. The need for repeat ERCP was the case in 18% in the stent group and 9% in the no stent group. The limitation of this study is that there is possibility that small residual stones were still present despite there being no filling defect seen on occlusion cholangiogram, which could have provided a nidus for stone recurrence. Also, I think the sample size is fairly small in this randomized trial, 66 patients only. So I think the fact that some of the baseline lab characteristics were significantly different is also a little concerning, I would say. And also, they do state that they did not evaluate the effect of choice of stent on stone recurrence in this randomized trial, as all patients underwent standard of care procedure for that institution, which was placement of a double pigtail plastic stent. So the main take-home point from this randomized trial is that in patients with choledochleothiasis with concomitant choledochleothiasis, placement of a prophylactic biliary stent placement after biliary clearance while patients are waiting for cholecystectomy may increase the risk of complications while providing no benefit in terms of reducing choledochleothiasis recurrence. A third and final study is a meta-analysis published in Gut comparing the various drugs in the treatment of active eosinophilic esophagitis. Eosinophilic esophagitis is a chronic progressive immune-mediated disease that's restricted to the esophagus that can produce symptoms of esophageal dysfunction and increased esophageal intraepithelial eosinophils. Drug options for EoE recommended by current clinical guidelines include PPI and topical steroids, but currently there are no recommendations regarding preferred drugs for active EoE because their relative efficacy is unclear. So these authors wanted to perform a network meta-analysis to evaluate the efficacy and safety of all drugs tested in EoE, that were either compared with each other or with placebo. So again, this is a systematic review and a network meta-analysis. They included randomized controlled trials comparing the efficacy of PPIs, topical steroids, or biologic drugs versus each other or versus placebo. They included all studies comprising adults or adolescents at least 12 years of age with active EoE with duration therapy of at least 6 weeks. So these authors ended up including 17 studies in this meta-analysis. And they do state that after looking at the 17 studies, 15 articles were eligible, including separate randomized trials of PPIs, topical steroids, and biologics versus each other or placebo in the induction of remission in patients with EIE. The 2 randomized trials were using PPIs, 9 randomized trials were using topical steroids, and 6 randomized trials using biologics. So this is the forest plot, first looking at the relative efficacy to achieve histological remission when the definition was the eosinophil infiltrate count of less than 6 eosinophils per high power field. So if you look at the treatment types on the left column here, now we can see they include biologics, they include budesonide oral disintegrating tablets, which are labeled as BOT here, fluticasone oral disintegrating tablets. And as you can see, they've ordered these treatments in terms of their efficacy compared with placebo. And these the way to interpret forest plots is that if these boxes with the confidence intervals cross this line here, it means that there is no difference between this treatment and placebo. And so anything above, so anything to the left of this line means that they were more effective than placebo. And when they perform a network meta-analysis, which means they look at all the treatments and then they rank the efficacy of each treatment compared to placebo and then to all the other treatments that were included in this meta-analysis, the authors found that lirentelimab, pardon my pronunciation, given at 1 milligram per kilogram, which is one of the drug studies and one of the randomized trials, ranked first and was found to be most efficacious in achieving histological remission in reducing eosinophil count to less than 6 eosinophils per high power field. When they looked at the ability to achieve histological remission, when they changed the definition to eosinophil count infiltrate of less than 15 eosinophils per high power field, so less stringent criteria, as you can see here, they found that budesonide was actually the most efficacious. The budesonide orally disintegrating tablet given at 1 milligram BID. Now, when they were looking at the ability of these medications to achieve symptom improvement, not just histological improvement, but symptom improvement, they found that budesonide orally disintegrating tablet, which is here given at 1 milligram BID, and budesonide suspension, which is here given at 2 milligram BID, these 2 drugs, and only these 2 drugs, were more efficacious than placebo, because as you can see here on this forest plot, is the only these are the only 2 medications staying on this side of the line here. When they were looking at likelihood of failure to achieve endoscopic improvement, they again found that budesonide orally disintegrating tablet given at 1 milligram BID and budesonide oral suspension at 1 milligram or 2 milligram BID was significantly more efficacious than placebo. So the take-home point from this meta-analysis is that it does support the efficacy of most available drugs over placebo for EoE treatment, especially when achieving histological improvement. However, the studies included did display significant heterogeneity in eligibility criteria and outcome measures, and therefore this limits the ability to establish solid therapeutic hierarchy. So to summarize, in contrast to previous studies, the use of CAD-E did not result in statistically significant difference in the number of adenomas detected, and additional studies are required to better understand why some endoscopists derive substantial benefits from CADI and others do not, and how best to use this novel technology in clinical practice. In our second randomized trial, we found that in patients with choledocholitis and concomitant cholelithiasis, prophylactic biliary stent placement after biliary clearance may increase the risk of complications while providing no benefit in terms of reducing choledocholitis recurrence. And finally, a network meta-analysis or randomized trials to support the efficacy of most available drugs over placebo for EoE treatment. However, unfortunately, the presence of significant heterogeneity in eligibility criteria and outcome measures among the trials included limited the ability to establish a solid therapeutic hierarchy. So our next journal club and final one for the year, my goodness, the year's gone very fast, is December 6th, 2023. I really hope you can join us next month. Please have a wonderful day, week, month, and we'll see you next month for people celebrating Thanksgiving. Happy Thanksgiving for November. Thank you. Bye.